Welcome, everyone. Thank you for joining us today for this conversation. I'm very, very excited to be hosting you today. Our conversation is about mental health financing in Africa, and we will be beginning shortly. Hello and welcome, everyone. Thank you so much for joining us today for this really important conversation on mental health financing in Africa, an area within public provision which is very underdeveloped and quite overlooked, not only during COVID-19, but even before. Mental health financing has been a low priority for public financing in health systems throughout the continent. And I'm delighted that this conversation is hosted in collaboration and partnership with Baobab Consulting, the Africa-focused social impact firm offering strategic communications and strategic advisory. So today we're speaking on mental health financing as part of Demand 6 of the Africa Young Women Beijing Plus 25 Manifesto, which is a political and feminist document co-created with 1,500 young women and men from 44 countries across the continent. And together we're taking this feminist political document to Generation Equality Forums to put the voices of young African women at the center and not at the periphery. I will have a chance to tell you more about the Nalafem Feminist Collective, but today we will focus on the mental health financing topic. And I'm joined by experts and advocates of mental health. We have Sheree Marshall, who is a researcher in global health at the Care and Policy Evaluation Center at the London School of Economics. And we have Chemutai, a musician, but also a mental health advocate. And the two have a huge expertise with work and advocacy in Kenya in particular, and with whom we will learn more and further about the various layers of mental health financing, not only in Kenya, but we will also speak about it from an African perspective. But before we dive into the conversation with Sheree and Sage, I'd like to invite my colleague Lara from Baobab to provide her remarks on today's conversation. Lara, to you.
Thank you, Amina. Welcome, everyone. We're very excited to be collaborating with the Nalafem Feminist Collective. So just for a bit of background on Baobab. So as Amina mentioned, Baobab is an Africa-focused social impact firm specializing in PR and communications, strategic advisory and research, and intercultural programming. Our company was founded in 2016 to promote a more equitable and culturally immersive approach to US-Africa partnerships with mission-aligned leaders, companies, and organizations, all with the aim of making an impact on the social issues that we are most invested in. So we were co-founded in St. Louis, Senegal, and we're currently headquartered in New York City with a team based all around the world in Senegal, Kenya, Rwanda, Nigeria, Tunisia, South Africa, and the United States. Since our inception, Baobab has been committed to women's rights, leadership, and advancement in Africa. We have worked closely with African women leaders, including Her Excellency Joyce Banda, former president of Malawi, Dr. Amina Fakim, former president of Mauritius, and Her Excellency Amina Toure, former prime minister of Senegal. Through PR partnership, we have had the pleasure of supporting countless events and campaigns focused on women's empowerment, including the International Sheroes Forum in Ghana, the launch of the Deliver for Good campaign in Senegal, and the African Women Leaders Network Intergenerational Retreat on Women Leadership in Africa and Kenya. We also served as the inaugural PR partner for Nigeria's first Oscar-submitted film, The Milkmaid, which highlights insurgency and violence against women and girls in Nigeria. We are therefore honored to be partnering with the Nalafem Collective to host today's webinar on mental health financing and to stand in solidarity with Demand 6 on mental health and well-being. We recognize mental health not only as a desired outcome for women's economic, social, and political empowerment, but also as services that require significant financial support to ensure democratization and equitable access for all, especially women and girls. So without further ado, I will pass it back to Amina to start the conversation.
Thank you so much, Lara, and we're so delighted and glad to having you join us in this solidarity journey, as you call it, on Demand 6, but also on further demands that were brought forward by Africa's young women. So in this conversation, we will be diving into how can mental health services be accessible regardless of financing? What does it take to finance mental health within Africa? And how can we actually move beyond stigma to make this pertinent demand present across social classes, genders, and throughout Africa's member states? And how can we also push forward at a grassroots level to ensure that our voices are heard? The conversation will be a hybrid between moderation and open conversation. So an open conversation means that the audience here with us needs to ask questions. So just to begin with, please do tell us where you're calling from, tell us your name. We would love to hear from you, and do send your questions throughout the conversation. So I would like to begin without further ado and dive in by asking Sage and engaging Sage. Perhaps Sage would love to hear more about you and about your work, if that's possible. And really, we want to understand what initiated your advocacy towards calling for the urgent need to access mental health services, and what are some of the overlooked experiences that young women faced, which you've encountered and which you feel should be spoken further about?
Hi. So I'm a singer, songwriter, and composer. That's my profession. And currently, I am the Wildlife Works brand ambassador. And yes, I have been vocal about my struggle with mental health issues because I have gotten depressed a couple of times in my life. I've been suicidal before. And I think the thing that pushed me to wanting to advocate for mental health awareness and access to mental health for all is it was right after I had my daughter. She's 7 now, but I suffered from postpartum depression. And I remember going for an interview once on a motherhood sort of, it was like a vlog of some sort. And I met this lady called Samoina, and she runs an organization here in Kenya called PPD Kenya, which is Postpartum Depression Kenya. And we got talking, and she was just basically explaining how she's trying to help both mothers and fathers get through postpartum depression, because for her, when she had her son, she didn't have access to any of these services and any of this knowledge. And it was the same for me. It's a thing that it's just, you're told, and it's just like brushed, like they just brush through it, like, oh, okay, so you'll have baby blues after you have the baby. But like what happens when it becomes deeper than that? No one really follows up or gives you the information that you need. So I think that was a thing that really pushed me to sort of getting into mental health advocacy. So How I've been advocating so far has just been talking about it during my interviews and being open about my experience, and also joining forums like these where people might need someone to sort of share their experience. So I've been very open about my mental health struggles, even on my social media, but mainly in interviews, both radio and television interviews. When I talk, like when I'm going to like launch new music, I always touch on the mental health part of my life. Yeah, sorry, what did you ask about there's something you asked.
Well, thank you so much for sharing. I really appreciate you joining us today and having this conversation with us. Yeah, the second part of the question is perhaps what are some of the overlooked experiences which through your advocacy and through telling and sharing your story with other women you've noticed that is an experience or experiences that are overlooked?
I think the experiences, I think one is that mental health is still a very stigmatized thing. When someone says mental health, people already, it's like they already visualize that it's a crazy person, and crazy in the sense that they like, I don't know, they just take it to extremes. The word mental health basically means mental well-being, but just the word mental health, not mental illness, mental health, people, like it has a very, I think people are like it's still a very stigmatized thing. So one, a lot of people don't have the knowledge or the education. They haven't been exposed to enough knowledge to know that this is an actual thing and it's a normal thing. And number two, access to mental health care. It's really expensive because looking for a therapist, you'll find that most of the therapists in Nairobi are the private practitioners. So for you to get one that's good for you, or who you feel comfortable talking to, it costs a lot of money, and that's not accessible to many of the young ladies out here, or men. Just it's not accessible basically because a lot of us are living, especially with COVID. I mean, there's a lot of us had to downsize.
Thank you so much, Sage, for sharing. I think Sheree will also have so much to add into the conversation. And you're right, I just wanted to highlight that, yeah, the stigma surrounding the word mental and the invisibility of our emotions also complicates a lot of how people understand, yeah, how they feel and how they can approach others. But also how, I think you really put an emphasis on an important point, which is, you know, the first therapy that you meet, the first therapist or psychologist that you meet isn't always necessarily the best one for you. And it's a relationship of trust that you need to build throughout, and it's not something that is accessible to everyone because of how pricey it is, and also because of how stigmatized it could get by friends, by family, by society in general. And I think it's so important to share one's story regardless of how difficult it may be, because you literally can be that bridge between you can be that bridge in helping someone realize what kind of supports they're looking for. Sheree, I'd love to turn to you and to ask from your work, just, you know, thinking about etymologies, what do we actually mean by mental health financing, and how does it relate to the larger care economies which exist or which are not existing when we speak of infrastructures? But more specifically, if we could later tell us a little bit about the kind of health policies that exist on the African continent. It's broad, but perhaps to focus on Kenya to be more specific. Please go ahead. Yeah.
Thank you, Amina. I'm very excited to be here today and to be speaking about this. So thank you to the Nalafem Collective and also Baobab Consulting. So yeah, just before I start, I just want to introduce myself. I recently just graduated from the London School of Economics with my master's in global health policy. Prior to that, I did my undergraduate in psychology, and I've had a passion for mental health advocacy from a young age. A lot of my research that I've been working on in the past year has been mostly in Kenya, but looking at deinstitutionalization of mental health hospitals in Kenya, South Africa, and Ghana. Just because, as we'll see today in this conversation, a lot of the care that is available for people is typically large institutions, and there isn't much at the primary care level or community care level. And so to answer your question, looking at what we mean by mental health financing, when we speak about that, we're talking about the mechanism whereby plans and policies are implemented through the allocation of resources. So in many low to middle income countries, many countries in the continent, less than $2 per capita is spent on mental health. And the majority of this funding typically goes towards mental hospitals as opposed to community-based services. So for example, in South Africa, less than 5% of mental health expenditure, or 5% of the total health expenditure goes towards mental health. And in Kenya, similar numbers, very little goes towards mental health. But this doesn't mean that there's no policies in place for mental health. So in South Africa, there's a national mental health policy framework and strategic plan. The same in Kenya in 2015, the government of Kenya created the Kenya Mental Health Policy 2015 to 2030 document, which provides a framework on interventions to strengthen the existing mental health systems within the country. So it's not that there aren't policies or frameworks in place to, say this is what we have to do in order to address the mental health of our citizens. It's more so that there's a lack of funding for these policies to be implemented. And so moving on towards how this relates to larger care economies or other health policies in Africa, there is a huge focus on communicable diseases throughout the continent. So historically, many of the policies and funding that comes either from donor funding or from the government is prioritized in infectious diseases such as malaria, tuberculosis, HIV and AIDS, illnesses that I suppose you could say you can see them and have more tangible effects through programs in the short term. And so this kind of leads to mental health being put on the back burner. And due to the barriers faced by those who are seeking services to mental health care, whether it's lack of infrastructure, stigma, lack of knowledge of mental health, geographical location, etc., mental health care overlaps with other forms of unpaid care that is given, for example, by family and community members. And a lot of the times, these family members and community members don't have a label or a name for what's happening. So families do suffer a lot in silence until a moment of crisis is reached, where a lot of people are then put into institutions, and it kind of becomes this revolving door phenomenon where you have people being discharged, there's no services on the community level, so they're put back into the institutions. So yeah, there's a lot to talk about in this field and in this area, but I'm excited to be speaking about that today.
Thank you so much, Sheree. And I think you touched on a point which also Sage highlighted, that sometimes, a lot of the experiences are immediately brushed through, like postpartum depression, for instance. If you haven't heard the term, you wouldn't know where to locate your body within that experience and within the larger social understanding of how you should be treating your baby after you give birth. And so I would like to go back to Sage and to ask you about experiences still, and how this need for mental health services and the provision of community-based spaces, like Sheree said, that would not silence women's experiences is important. And so these are spaces that would be beneficial, not only coming top down, but also, you know, created by the communities that surround us. So how can we bridge between that which can be seen and with concrete policies that would protect us when it comes to the provision of mental health services?
Thanks, Amina. I think one of the biggest things is obviously educating, the education part. The community needs to be educated on mental health, mental illnesses, and what they actually look like, what it actually looks like. Make it something that they can at least visualize. Since it's unseen, let it be something they can visualize, or let it be something that they can make into something tangible of some sort. And the second thing, and especially, I think people think mental illness is something that only affects older people or people of a certain age, but kids also suffer from mental illnesses. So I think it's something that, one, they should start teaching in schools. And then, yes, at a community level, they need to have those discussions within themselves in the community. So to be able to make policies and policies that will stick, it has to be of importance to the community, because if it's not important to the community, or if it doesn't feel like something that they know, because people have a fear, they fear things that they don't understand and things they don't know, or things they feel don't belong to them, or things that they feel don't affect them. So it's important for people to know that these things, they affect you. They are things that have affected you before, and this is how we can make the situation better. So I feel like making policies will only make sense, and making policies stick will only make sense once the community is educated on the mental health and mental wellness.
Thank you, Sage. Sheree, I saw you were nodding. Is there any point you'd like to add to this question?
Yeah, so something that stuck out to me with what Sage just said was how in creating these policies, you have to interact with people within the community. And I think that that's so important, because a lot of the times when the policies are made in a top-down approach, you can miss different cultural or specific factors within certain communities. Like even looking at Kenya, being such a diverse country, certain interventions may not work in different communities just based on culture, religion, the age of the people that you're targeting. And also going off of what Sage has said as well, the focus being on mental illnesses in adults, where adolescence is a very vulnerable period for the onset of mental illness. I think it's something like 75% of mental illnesses are diagnosed before the age of 25. So there needs to be, policies targeting schools and children in these schools, to just create a dialogue so that people can know, where can I access services if I need help, or even just signs to look out for if you're a parent and your child, things like that.
Thank you so much, Sheree. I think there is a question in the chat which is an important one to perhaps dive into, and it asks from an anonymous attendee, what are the factors of stigma? Feel free, yeah.
Yeah, so stigma within mental health is, it's huge, and especially in Kenya. I think that one of the biggest factors underlying stigma is lack of dialogue, ignorance, or views that mental illness stems from either like evil, or just not having the correct facts about what mental illness is. And speaking about Kenya, there's a huge issue when you talk about people with mental illness, because the term like Madare has become a derogatory term. Madare is the largest psychiatric hospital in the country, and that's a term that's used loosely in many settings to refer to someone who's crazy, or if someone does something, you'll say, oh, they should go to Madare. So just discourse like that puts a very big, like aspect of shame when people start speaking about mental illness, because people view it as, if I speak about this, people will associate me with XYZ. So I'd say that one of the biggest factors that goes into stigma is just ignorance and lack of dialogue and misunderstanding of what mental illnesses are. And yeah, it's a very big topic. So if anyone has anything else to add, maybe Sage.
I think what I'd add is, and this is me piggybacking off what you've said, but I would sum it up as fear. The fear of the unknown, the fear that, because as you said, how people loosely use the Madare as like to say, oh, you're crazy, you should be taken to Madare. I think it's also that fear of being associated with something, or the fear that saying you have a mental illness means you are incapable of living. It's like someone tells you, oh, you have a mental illness, so you're incapable of this, so we will not include you in this, or it means you lose out on job opportunities or just on being able to socialize as a regular person, which is not the case. But there's that fear, and I think it is rooted in a lot in religion, or like in in some African traditional practices. So it feels like, yes, it's all summed up in one. People there's that fear, and the ignorance, I feel, as well stems from being afraid of knowing, because you're afraid of knowing because you're scared that you'll find out that you have a mental illness, and then what does that mean for you? I think that's pretty much it.
Thank you so much, Sage and Sheree. And yeah, something came to mind as I was thinking about the context where I'm at, which is in Morocco, and thinking about stigma and shame, and realizing that actually if a person is unsure about what's going on, they can't go to the community-based health center because there's no therapist, there's no psychologist, there's no one to actually accommodate them. And they would immediately be directed to the equivalent of Mathare here in Morocco. And that is also expensive because you have to pay for each and every night that you spend there. So it's not even accessible to each and every person. There's a really interesting question in the chat from Solomon, who's asking, as African, how can we explore the existing culture and traditional good practices and resources in treatment of people suffering from mental health challenges? Most of our policies and strategies lack understanding of local context and have top-down approaches.
That's a great question. Just speaking from different, I guess, papers that I've read that have tried to address this gap, I think that, like we mentioned before, it's really important to develop policy and develop strategies in the community with people who live in that community. So, for example, there's been studies that have shown that training community health workers that live within certain communities in mental health, active listening, or in trauma counseling helps, because people in the community trust these community health workers if they know them. It's someone that is aware of the contextual, cultural variances in that setting. Whereas instead of having, someone from, say, like Nairobi or elsewhere go into a community that's 8 hours away and try to give that same counseling. But yes, I think that the biggest factor is that when we're developing these policies, when we're trying to implement change, you need to have space at that table for people from those communities, because many times it's, you can read a textbook and say, well, this will work because it worked in X location, but you might be missing a huge contextual factor because you're not from that community, or there just might not be that trust, because a lot of the times too, in many cultures, it's viewed as we don't share our family problems with strangers. We don't speak about our issues at home with a random person, So a bridge to that could be, well, if it's someone from the community, maybe there'd be that trust as opposed to having someone from outside coming. So I think that would be my answer to that.
Thank you, Sheree. We have in the chat a really important perspective from Nigeria, and I would like to read it if that's okay. So Hossein Zayad says that in Nigeria, orthodox mental health practice is characterized by paucity of facilities and mental health professionals, with concentration of care in the relatively few available psychiatric hospitals and psychiatric units of some general and teaching hospitals. Some studies in Nigeria have shown that respondents, as well as health workers, believe in the effectiveness of orthodox treatment. However, despite that belief, it's found that the general public and health workers still maintain negative attitude towards people with mental illnesses with negative consequences. So I think perhaps there's a question that comes out of that, which is the relationship between the practitioners and the people looking who are supposed to provide ease or provide supports in the journey of the mental health journey within the hospital, when they're not actually on the good side, or they're not supporting in ways that are inclusive, or in ways that are fully eradicated of stigma within that hospital space as well. Said Sheree, I'm not sure if you have experience within this specific point, or a remark that you'd like to highlight.
Yeah, I think that in regards to that, I think that's why it's so important for us to not only have policies and not only build mental health at the primary care level and the community level, but also foster conversations that break down the stigma, because at the end of the day, many health workers are still coming from communities who maybe will hold negative views of people with mental illnesses, or also, there's a wide range of mental illnesses too. So I think that it can vary as well with people's perceptions of what that means. But yeah, I think that alongside building mental health at the primary care level, community-based mental health options, you also have to be having conversations to break stigma within people who work in that field, because at the end of the day, they are coming from a community or society which generally may not have positive views regarding mental illnesses.
Sorry, I'm Amina, but I'd like to agree with what Sheree said. Yes, conversations are very important, and I feel like the more the conversations are had, the more the less it becomes something that's stigmatized, the more open they'll probably be. And I think it's important for hospitals to hold training for their staff and for the health workers, in order for them to also understand more about what they're dealing with on a day-to-day basis, so that they're not coming from a place of, oh, I'm coming to work and I just have to do this, and still come in with their prejudice or with their preconceived notions about mental health. but to also come in knowing that this is what we're dealing with, and it's not something to be afraid of or to treat others differently about. Yeah.
Definitely, because at the end of the day, the hospital will continue to be seen as that safe place and that safe haven, and it would be unfortunate not to make it inclusive and not to make it safer, I would say. There's a really interesting question by Brenda Mrendi, and it's about Kenya specifically. And she's asking, before we can even focus on mental health financing, can we talk about the fact that a country like Kenya has no professional board for psychologists and counselor? And so what kind of approach should we focus on? Should we think about a change or incorporation of approaches? Because for a long time, the approach has been used in the psychiatric one, bearing in mind that many health challenges are not pathological, but rather normal reactions to life challenges.
Yeah, that's a great point. Thank you, Brenda. Yes, I agree that there definitely is in Kenya specifically a very biomedical view or approach to seeing mental illness, rather than a holistic care approach. So, like you're saying, a lot of it is focused on psychiatry and medication and big hospitals and institutions where people are put in, without taking into account that a lot of other factors such as occupation, community, there's so many different factors that tie into mental health. COVID, which in the past year, I'm sure has exacerbated a lot of mental illnesses with isolation and lockdowns. So I think that that's definitely part of this as well, is also changing that narrative that mental health and mental illnesses are only biological and can only be fixed through medication or through being hospitalized. Because then, like I mentioned before, what happens is that when people are admitted into institutions, they're given medicine, they're discharged, they don't have the support within the community to then, maybe find work. There's stigma with the labeling that they get from being in these institutions. Maybe they can't afford their medication. There's so many other factors that come into creating like holistic mental well-being that aren't taken into consideration. And I do think that having a professional board that has psychologists, counselors, social workers, occupational therapists, that's all important, because mental health has so many different facets that it covers. So thank you for the question.
Thank you, Sheree. And I think I have a question too, which ties to this answer of how do we envision this mental health to be put in place? So when we think about impact, when we're thinking about change in the landscape of mental health, and making sure that the resources that are needed are going to the places where they will be the most effective. So I just wanted to do a little exercise of imagination with you, please tell me what comes to mind when you hear the word impact and change within this landscape of mental health financing.
Yeah, so thank you for that question. I think that for me, what comes to mind when I think of change, I think of the implementation of the policies and legislation that has been written out. As we've spoken about today, there isn't a shortage of mental health advocates in Kenya and throughout the continent. There isn't a shortage of policy frameworks or documents that argue for the need to increase access to mental health services, to make them more available, and to break down the existing barriers. Therefore, I think that the next step is implementation of this. Change for me represents having these ideas stop being ideas and becoming a reality for those with mental illnesses. So whether that's increasing human resources in the mental health field, improving infrastructure or the health system, allocating more resources to mental health, breaking the stigma surrounding mental illnesses, or just integrating mental health into primary care and at the community level. I think that change for me is action and not just relying on these documents that are being created and acknowledging that this is an issue and we're spending so little of our health budget on mental health. It's like, yes, that's true, and we're having these discussions, but the next step is implementing it and finding ways to implement it. And as for impact, in this field, I think that impact would be seeing the effects of the aforementioned changes, that would be like the effects that would have at the individual and societal level. So where individuals with mental illnesses are being catered to in a very direct way instead of it being like a conceptual idea, making individuals feel the effects of what you're trying to implement. And additionally, I think that impact is having these changes be facilitated by persons with mental illnesses in order to ensure that people's lived experiences are being taken into account. And then on the societal level, I would say I see impact as being able to speak about mental health freely and without judgment, breaking down those barriers that are caused by stigma and having people's voices be heard, because I genuinely think that stigma is one of the biggest barriers to attaining many of the goals that we've spoken about today.
I think Sheree put it perfectly. I think I'll just add one thing for me is I feel like change and impact for me would be reflected by mental health just being seen as part of health. Like when you say health, I want people to not only think physical, but mental as well, and not for the two to be exclusive. And for, yes, the health budget, for more money to go towards mental health, because that's important. I don't think that governments know how important it is for their citizens for their mental well-being of their citizens. A country like Kenya, where the women are a majority of the working force, to have access to mental health only makes where's the word? It will sort of strengthen the workforce. And I know that's what every country would like. So yeah, I would really love for mental health to not just be some mental health like it's exclusive to the human being, but for it to be included from physical, mental. For me, change would be seeing it accepted as part of the human health. We can call it human health.
Thank you, Sage. I think that's such an important suggestion. I hope everyone is taking notes, and it's something that they will, one of the things that they will take out of this conversation is perhaps trying to shift the etymology that we approach this topic with. And I agree with you. I think it's so important to also provide mental health services that understand also the impacts of daily sexism and misogyny and discrimination that young women are faced with. And this is a clear demand that the Africa Young Women Beijing Plus 25 manifesto brings forward. And I think what this conversation has done today is also challenge the idea of the able-bodied, young person or the able-bodied subject and human, because we need to rally around the elimination of any obstacles that may have negative implications for the full integration of mentally and physically challenged youth into society, which means the provision of appropriate infrastructure and services to facilitate integration and access to opportunities free from discrimination, which I think Seiju really dived into it in the beginning. The fear of speaking up is also linked to a fear of being limited from opportunities or being seen as not fully human or deserving of certain to be in certain spaces, which is something to rally against. So when we think about implementation and how to push forward, I just wanted to also highlight that this political documents which we're talking about today, and which Demand 6 is very much part of, has been co-created with young people from 44 different African countries throughout the COVID period, specifically last year during the mandate of the African Union Youth Envoy, AHLB. And the idea is to take the manifesto and to bring it to Generation Equality Forum. So to break it a bit further, because sometimes United Nations frameworks can be hard to understand for a lot of us who are not part of this space. So Generation Equality is a forum that is convened by UN Women and co-hosted with France and Mexico. And it's supposed to be and aimed at being civil society centered and supposed to be a global gathering for gender equality. It's an international forum, and international also includes Africa with its 54 countries. So the idea is to really ensure that African women's voices are not marginalized, and that African women's demands are being heard, and that African member states are also going to be held accountable for making sure and ensuring that these policies will be put in place. But I think from our conversation today, and from something that what we know from our experiences and what we're advocating for, is these policies need to be grassroots, and they can't be top down. I really loved it when Sage, you said, policies that stick need to be of importance to the community. And this is something that a lot of people who are at high level of decision making need to take into consideration, that policies need to take into consideration an aspect of educating youth and young and society around mental health, and really ensuring human health. Let me correct you and use Sage terminology around human health, but also ensure that it's provided across spaces in schools, in community-centered spaces, and for everyone, regardless of which socioeconomic background you belong to. There's a comment in the chat from Brenda that says human resources can also be part of mental health financing, in the sense that governments employ more mental health professionals to serve people even at the grassroots level. Absolutely, I think human resources are definitely part of this paradigm of financing, because it means support. It means that you don't feel alone, and it also means that you are supported throughout the journey. And for me, listening to this conversation to two experts, Sheree and Sage, I think I took out so much, not only from understanding how to approach and think around the stigma that surrounds invisible illnesses, which we're often not encouraged to speak about, both within family structures and frameworks. But I also wanted to share that the Africa Young Women Manifesto needs your support, and we're trying to gather signatures for the manifesto and to mainstream it to people, and to say that these are actually the demands that African young women are asking for. And these are demands that we all relate to. So if you feel like it speaks to you, please make sure that you sign it, and that you speak about this as widely as possible, because I think this is a really important time for us to rally and to make sure that spaces like Generation Equality Forum doesn't move forward without Africa. But before we close, Sheree and Sage, I would like to open the floor to you if there is any final word that you'd like to say or share with us today. And I would also just like to thank everyone who sent questions, and for the continuous engagement on the Q&A and the chats. Please, let's continue this conversation. Let me not end here. Sorry, Sheree, Sage, please go ahead.
Yeah, thank you so much, Amina. To close, I'd just like to say that I'm very happy that I was able to be here today. I'm very encouraged to see how many people joined and all the questions that we were able to discuss and engage in today. I think that these conversations are very important, and like I said, I'm really looking forward to seeing the implementation and the change, so that it's not just policies and writing policies, but more so just making sure that what we're speaking about becomes a reality. And so yeah, thank you so much, Amina, and thank you, Sage, and Baobab Consulting, everyone. Thank you.
So it has been such an honor. When I was asked to be one of the panelists, I freaked out. Amina knows this. I was freaking out so much. But it has been such an honor to use my voice to speak about something that I have gone through, and also to sort of engage with like-minded people. I have read some of the comments in the chat, and wow, I'm happy that people are being more and more vocal about these things. It has been an honor sharing the stage with Sheree. You are such a brilliant mind. Oh my gosh. I only heard about you because of this, but I am, if you have anything anywhere where I can just go and like look for you and read more about you, I am super interested in getting to know the sort of work you have been doing. Thank you so much, Amina. Thank you, Nalafem. And thank you to the Baobab Consulting for having me. It has been such a pleasure. Thank you. Oh, and thank you for everyone who has attended.
Thank you so much, Sheree and Sage. And I think, yeah, just to end and to close, I think it's so important to think that as young African women and as youth, we're not at the periphery of what is happening at a policy level. And I think, Sheree, you're very much within the policy space, and you're working towards that. And it's something to really applaud you for. And yeah, Sage, you're using your voice through alternative media, through your music, through your art. And I think it's these collaborations that happen across these two spaces, which a lot of people may often see as disassociated or not necessarily in conversation with one another, that could bring the large impact. So I'm really excited to see what kind of collab would come out of this conversation between the two of you, especially that you work both in Kenya. So I hope, I hope to hear more, and please do let us know. And if you want us to promote any of your work, we would also be glad to do that at the Nala Feminist Collective. And I also wanted to end by saying that the Nala Council is also committed to working towards pushing for the manifesto to be included at larger policy spaces. And we have incredible women who make part of the council, like the former AU Youth Envoy, Aya Chebi, the former Minister of Trade of Botswana, Bogolo Kenewendo, Miss Universe, Zosi Tunzi, Yasmin Abdelmajid, who's a writer from Sudan, and many other ones who are also working on a daily basis to improve the lives of African young women. And it's something that we're also, I think, all committed to here if you've joined this webinar. So thank you very much, everyone. And please, let's continue the conversation. Do follow us on Twitter, Facebook, and Instagram. Make sure that you join our webinars that take place every Wednesday. We will be moving to intergenerational dialogues moving forward. So bringing in elders to speak with youth on matters such as these and on the demands of the manifesto. And please do sign the manifesto and share it with your family and friends. And I was very delighted to host you. My name is Amina, because I forgot to introduce myself. My name is Amina, and I am the social media manager for the collective. So I wish you a great afternoon, and thank you once again. Bye-bye.